The following podcast is part of a certified educational activity titled Customizing Care in Chronic Lymphocytic Leukemia with Btk Inhibitors. Evidence and applications for therapy selection, sequencing, and safety management. Access the entire activity and complete the post-test at peerview.com/HZU860. Downloadable slides and practice aids are also available.
Welcome, to the Customizing Care in CLL with Btk Inhibitors, evidence and application for therapeutic selection, sequencing, and safety management. I'm excited to be here with Dr. Jacqueline Brentis and Dr. Carrie Rogers. I'll start with the introduction. We're here talking about CLL and targeting BCR or B cell receptor signaling. And where does Bruton's tyrosine kinase fit? And first of all, let's see if everybody is awake. Who's heard of Bruton's tyrosine kinase? Raise your hand. Yay. So somebody's awake. And so I'm going to refer to Bruton's tyrosine kinase as BTK, as will Dr. Brentis and Dr. Rogers. Don't get on your iPad, go to Google and look up BTK on Google, because you'll come up with something awful that has nothing to do with Bruton's tyrosine kinase. Why do we care about Bruton's tyrosine kinase? We care about Bruton's tyrosine kinase because in B cells, it's at a critical node. And by node, I mean a light switch channel that includes B cell receptor signaling. It includes the integrin ligand, CXCR4, CXCL12, and other integrin-related signaling and adhesion molecules that protect B cells from death by maintaining them in their microenvironment. And finally, it sits right in the middle of a complex that's involved in toll receptor signaling, called MyD88. It's a binding partner of that. And then if those three aren't enough, it goes into the nucleus, and it probably has a transcriptional role. So when you think of things simply, and I like to think of things simply because I was in the Army once, and they always taught us to think simply about problems. And I'm also from Arkansas, where we think about things simply. So when we think about things simply, and we think about these three paths that that CLL and particularly Waldenstrom's work, and other malignancies, when B cell malignancies are dependent upon one or two of these nodes, these drugs often will work. When you're lucky and you have a disease like CLL or Waldenstrom's macroglobulinemia, where the disease is dependent upon all three of these axes, these are game-changing drugs. And for sure, CLL and Waldenstrom's, where you can see really durable remissions with these, you see very, very durable remissions, and we'll be talking about this as it relates to CLL today. We have a number of Btk inhibitors that are FDA approved, Ibrutinib and acalabrutinib. We have another one that's in the compendium and the NCCN guidelines, zanubrutinib, a second-generation medicine like acalabrutinib. And then we have this pirtobrutinib, which is in phase 3 testing, and there are many others that are coming. We only included molecules that are in phase 3 studies at this time. As we look at where these fit in, and I didn't recognize how much people use NCCN guidelines for sort of deciding what they're doing when they're in general practice until I really immerse myself in my new position with talking with general oncologists. But these are widely used, and you'll notice for really all types of CLL, are the top level 1, category 1, that means phase 3 data is demonstrated, include Btk inhibitors. And then there's this Renegade, Venetoclax, and Venetuzumab, regimen that we'll talk about. I say renegade because we're talking about BTK inhibitors, but that's also a category 1. So don't walk away saying that, this is not, Venetoclax is not an important drug either. Dr. Rogers will talk a good bit about this. So we certainly have patients who fall into certain populations in the relapse setting where these are also category 1. And again, our BTK inhibitors that are approved, Ibrutinib and acalabrutinib, both lie there. So they're at the top. What's the problem with these? Well, I think when you do clinical trials and patients are real motivated to go on to new therapies, you really have great compliance. However, when you get things out in the real world and patients take a medicine, maybe they're not as motivated to take the medicine as a patient that goes on a clinical trial. All of a sudden, an adverse event that didn't bother that highly motivated patient really does lead to discontinuation. And 2 studies, one done by Dr. Motto and another that would parallel this in Europe, demonstrated that, particularly with the first generation BTK inhibitors, a great number of patients would go off for adverse events. And these can include atrial fibrillation. If you get that, nobody's going to question. But even things like diarrhea or arthralgia, and if your hand cramps up while you're driving, and you're a truck driver, it's probably a good idea to think about not taking that. Particularly if you're in a small car and you're asked and you're in a small car driving down the Pennsylvania Turnpike. So how the drugs that we have Ibrutinib, and why do we see this? Why do we see this differential adverse event profile? Ibrutinib is a great drug at inhibiting BTK, but it also hits a variety of other things. The red things show other targets that it's hitting. Whereas we have these second generation BTK inhibitors that we'll talk a good bit about, acalabrutinib and zanubrutinib, that hit very less targets, and acalabrutinib hits about 5, zanubrutinib a few more. And so by knocking out these different targets, by not hitting these different targets, we see less toxicity, which ultimately allows the patient to stay on therapy and to tolerate therapy better. So these things, these, as I said, these alternative kinases, and I just throw up 2, TEC and EGFR, actually probably explain a good number of the alternative side effects, particularly bleeding with TEC, because it's synonymous with BTK. But when you hit both, you tend to see more bruising. Then EGFR obviously can cause rash, diarrhea, and arthralgias and other things. But we also have another issue with these drugs, and I'm looking forward to Dr. Rogers' address of how we sequence our drugs to prevent resistance. And again, if you question the importance of the node BTK in CLL, the pathway of resistance tells us it's pretty darn important, because when the cancer cell changes something in the target to outsmart a drug, that tells you that target is important. The cancer can't bypass it and live. So we'll hear about this, and most of the mutations that occur in CLL are involved in either BTK or in downstream, Plc Gamma 2, where again, that pathway through BTK is maintained. So our agenda is shown here. Dr. Brentis is going to talk to us about treating BTK inhibitors in the front line, including in high-risk settings. I'll follow her talk and talk about safety and my consideration in patients when I'm picking a BTK inhibitor for patients. And then finally, Dr. Rogers will talk about sequential use of BTK inhibitors and how they can be, when our CLL outsmarts the BTK inhibitor and the drug fails the patient, that we can go to other options. So I'm going to turn this over to Dr. Brentis.
So thank you very much. I'm here, delighted to be here with my colleagues at this talk. I'll be talking about the frontline treatment strategies for patients with a CLL diagnosis. So this is the clinical consult. An older patient, Matthew, with CLL presents with high-risk disease, 72-year-old man, good performance status, demonstrates anemia, thrombocytopenia. He also has well-controlled hypertension, COPD, and his FISH analysis shows 17p deletion, 13q deletion. He's mutated for TP53 and he's unmutated for IGHV. So what are the treatment options for Matthew? Continuous BTK inhibitor therapy or Venetoclax with obinutuzumab. If it's a BTK inhibitor, which one would be appropriate? And is there any role for chemoimmunotherapy? So how do we decide on therapy? Based on the current clinical evidence, and I will discuss this in the next couple of slides, the inhibitors of BTK are highly effective in patients with a CLL diagnosis that carry the TP53 mutation. Venetoclax and obinutuzumab are active compounds, but the outcomes are less robust in this setting, and there is absolutely no role for a patient with TP53 mutation to receive chemoimmunotherapy. So there's plenty of phase 3 evidence that supports the use of BTK inhibitors for frontline treatment of patients with CLL. For Ibrutinib, we have the RESONATE-2, which compared monotherapy against chlorambucil, Illuminate, which included the combination regimen with obinutuzumab against chlorambucil and Venetoclax and obinutuzumab. ECOG 1912 and Alliance trials both were very similar trials that compared Ibrutinib against FCR or BR depending on your age and fitness. Acalabrutinib had the ELEVATE-TN trial that showed a superior PFS and a better trend for overall survival with acalabrutinib regimens against obinutuzumab and chlorambucil. And last but not least, it's a Sequoia trial of zanubrutinib against BR showing superior PFS against BR. Now, the longest follow-up with, of course, with the first in-class drug, Ibrutinib. This is the data from the 7-year follow-up from RESONATE-2, which continues to show a clinical benefit of monotherapy with Ibrutinib against chlorambucil. The benefit was similar for mutated and unmutated IGHV. Because the patients were randomized to receive chlorambucil, this clinical trial did not include patients with a TP53 mutation or deletion 17p. But as you can see here, the median PFS has not yet been reached, even at 7 years follow-up. In terms of how does acalabrutinib do, this is the longer follow-up from ELEVATE-TN showing sustained PFS benefit with acalabrutinib plus or minus obinutuzumab. Very clear, remarkable improvement where the median PFS of obinutuzumab with chlorambucil was reported at 27.8 months against 87% and 78% median PFS was not reached for either arm. The study was not designed to compare whether or not the addition of obinutuzumab was statistically significantly better than the monotherapy. So as of right now, even though there is a trend, it's not possible for us based on the data from the trial. However, if the patient is fit and tolerate, could potentially use this drug. With the data in terms of safety, we saw that there was a higher incidence of neutropenic events and infections when obinutuzumab was added. In unmutated IGHV subgroup analysis for the original publication, the 24-month PFS was 91% for patients that received acalabrutinib with obinutuzumab. And last but not least, in terms of the phase 3 trials, zanubrutinib prolonged PFS against BR in treatment-naive CLL, and this data will be presented at this year's ASH on Sunday at 10:45. It randomized patients to zanubrutinib against BR, and this study did not include patients with 17p. After a median follow-up of 26 months, the PFS was significantly prolonged with zanubrutinib, and this benefit was observed across subgroups that included age, bulky disease, and deletion 11q presence. And the treatment benefit was also observed for patients with unmutated IGHV, which we know do relapse sooner when they're treated with chemoimmunotherapy. In terms of the pivotal frontline studies comparing chemoimmunotherapy against a BTK inhibitor, how do the patients with 17p deletion do? As you can see here, even though the numbers are small, they're actually pretty good. We have solid evidence from the Alliance, Illuminate, and ELEVATE-TN trial that these patients do very well with median PFS not yet established or reached at the time of the presentation of the analysis of the data. Much better than patients that were treated with chemoimmunotherapy, where the median PFS was very short, in a matter of months. There is the data also from the NIH group on the right side. As you can see, the long-term follow-up of, even though it was a small number of patients, 34, you see that over time, the overall survival and the median PFS is remarkable, improved compared to what we could expect from the patients that were treated before with chemoimmunotherapy approaches, where the overall survival was expected to be between 2 and 3 years because we didn't have these novel agents. At this year's ASH, we will have an update from the Alliance trial that compared Ibrutinib plus or minus rituximab against BR in patients that included the patients that had 17p deletion or TP53 mutation. And as you can see, there was a greater benefit of Ibrutinib regimens over chemoimmunotherapy. This was expected. We already kind of were, this is not a surprise for us. We knew that this was going to be the case. And there was no significant difference whether or not the patients had or did not have the TP53 mutation. In terms of the phase 1 trial of acalabrutinib, at the 53-month follow-up, there is continued benefit of acalabrutinib therapy in treatment-naive CLL. As you can see here, there was a large number of patients compared to what we usually see in our clinic. We usually see about 10% or less of patients frontline with a diagnosis of TP53 mutation, but here you see that there was an 18% of the patients had the TP53 mutation. In patients with a TP53 aberration, the 48-month PFS was 82%. And that is really good. And overall, the 48-month PFS was 95.7%. And the median duration of response has not been reached. In terms of the ELEVATE-TN, which is the study that compared acalabrutinib plus or minus obinutuzumab against obinutuzumab and chlorambucil with a median follow-up of 4 years, as you can see here, the progression-free survival is at this time very, very remarkable. Both groups have very good remission durations compared to what has been expected with fixed duration regimen of obinutuzumab with chlorambucil with a median PFS of 17.5 months. In the CLL14 trial, we saw the outcomes recently of the longer follow-up of the fixed duration regimen of Venetoclax with obinutuzumab. And what it's becoming clear is that even though this regimen is very effective, the data shows us that the presence of unmutated IGHV or deletion 17p comes with it's an unfavorable prognostic factor, even if you receive Venetoclax with obinutuzumab. And this is for the reason that we think that maybe these patients should benefit more with daily continuous daily dosing. Or maybe this was not the best combination. Maybe Venetoclax does work with other drug with addition of Ibrutinib or another Btk inhibitor, and I will mention that in the coming slides. So would Matthew be a candidate for Btk inhibitor-based combination? And what are the treatment options? Is there a role for CD20 monoclonal antibody use? Or what about using Venetoclax with a Btk inhibitor? So let's discuss that. In terms of data with monoclonal antibody addition, as you can see here, Illuminate showed an improved PFS when patients were treated with Ibrutinib and obinutuzumab. Unfortunately, this trial did not include a monotherapy arm as a comparator. And in terms of the alliance, there was a comparator. There was a Ibrutinib arm that was monotherapy or Ibrutinib with rituximab, and there was exactly no difference amongst the two arms in terms of adding an additional benefit. So that's the reason why, as of right now, in terms of Ibrutinib use, we would not include another monoclonal antibody unless the patient would require it, for example, if the disease is advancing very quickly or very rapidly, or there's an episode of autoimmune hemolytic anemia or another autoimmune complication that would benefit from the addition of the monoclonal antibody. In terms of adding obinutuzumab to acalabrutinib, what we are seeing from the 4-year update is that there are definitely higher rates of undetectable MRD with the combination treatment strategy. And in post-hoc analysis, the HR for PFS between acalabrutinib with venetoclax and acalabrutinib monotherapy was 0.49. As you can see here, patients that were treated with the combination of acalabrutinib with obinutuzumab, they had a much higher level of undetectable MRD in the testing. So what about combining a Btk inhibitor with venetoclax and that this make a difference? There are two studies that have happened. The Captivate is the phase 2 trial that did a fixed duration treatment strategy of ibrutinib with venetoclax. And the primary endpoint was achieving the fixed duration cohort in patients without deletion 17p, meaningful improvement over the 40% rate that was obtained from the historical cohort of FCR in CLL10 trial. And so in this matter, we obtained, the study group found that 56% of the patients achieved undetectable, the complete remission rate. And even though it was not in the part of the primary endpoint, as you can see here on this slide, the patients with a deletion 17p or TP53 mutation, which were 27 patients, they basically achieved the same overall response rate and the same complete remission rate. Now, patients that were treated in the GLOW study, which is a phase 3 study for older patients that were randomized to ibrutinib with venetoclax against obinutuzumab with chlorambucil in treatment-naive patients, patients with 17p deletion were not allowed to participate because they would have received chlorambucil as one of the comparators, and that is not something that we recommend. We don't want patients to receive chemoimmunotherapy because we know that it doesn't work. However, the combination did reduce the risk of progression or death by 78% when compared with comparator. The only issue that I see with this particular study is that when you look at the outcomes in terms of discontinuation and in terms of toxicity, there are more toxicity events that are witnessed or observed on patients that are elderly. So maybe the treatment strategy of combination is not as good for an elderly patient, and it might be reserved better for fitter patients or younger cohorts. Another treatment strategy is novel treatments, triplets, ibrutinib, venetoclax, and obinutuzumab. This is showing, or IVO, showing Dr. Kerry Rogers, my colleague here, presented this data of this phase 2 study in patients with treatment-naive disease and relapsed refractory disease. And the overall response rate was 84% in treatment-naive patients and 88% in relapsed refractory disease. Patients were able to achieve undetectable MRD in the majority of the patients. And at a median follow-up of 24 months in treatment-naive patients, the median PFS and the overall survival have not yet been reached. This treatment strategy is safe, and it's now being conducted in larger studies. This was just the original study. Other time-limited treatment strategy is the regimen AVO, recently published in the Lancet Oncology, time-limited acalabrutinib, venetoclax, and obinutuzumab. The primary endpoint was not met because it was complete remission with undetectable MRD. However, the regimen was very active with very high rates of notable complete remission rates across patient populations. And there was a high proportion of patients with undetectable MRD in the bone marrow, which supports further investigation. As such, this study is also part of the backbone for a new phase 3 trial. As you can see here, even in patients with TP53 mutated disease or undetectable or unmutated IGHV, you see that the patients are able to achieve over time CR with undetectable MRD in the study, in the laboratory. And last but not least, we have BOVEN. BOVEN is zanubrutinib with venetoclax and obinutuzumab, very highly active with robust undetectable MRDs in treatment-naive CLL rates. This is a phase 2 trial, 39 patients, and what we saw was 89.2% of patients achieved undetectable MRD in the peripheral blood and in the bone marrow, and stopped therapy after a median of 10 months. The results improve over time, and as you know, most of these treatment strategies, they do staggered. They start with one agent to debulk, minimize the risk for TLS, because venetoclax is one of those drugs that we know that may put the patient at higher risk for TLS development. And then over time, what we see is that with the addition of the other agents, we can achieve these deep remissions, which end up correlating with longer progression-free survivals and overall survivals. So even though we are not there yet in terms of curing, we are hoping that at some point we can give our patients time-limited treatment strategies that allow them to have no need for further therapy for a good solid time, such as what we were able to achieve in the past with chemoimmunotherapy regimens such as FCR and BR. So these are our take-homes from my talk. When you select upfront BTK inhibitors therapy, please be aware of the baseline prognostic features. Study by the Informed CLL registry presented recently showed that less than a third of the patients actually get tested for mutations of IGHV and for TP53 mutation by next-generation sequencing or by deletion 17p by FISH analysis. Now, first and second generation BTK inhibitors are active choices in patients with a TP53 mutated disease. The current data suggests that the highest benefit for our patients with this particular mutation is with continuous daily dosing. As of right now, it hasn't changed. So we would recommend the use of a BTK inhibitor, and time-limited treatment strategies continue to be evaluated with different combinations as doublets or triplets. And with that, thank you for your attention.
Great. We're not going to let you off. We're not going to let you off the hook, say, because you covered such important, such important data. You talked, you sort of first generation CD20 antibody, first generation BTK inhibitor in the Alliance study, no benefit. CD20 antibody for a decade and a half, dramatic benefit in CLL with chemoimmunotherapy. So second generation, this really the Elevate treatment naive was those curves looked pretty good, say, with the combination. And so it's where I'm just curious, say, where the two of you use CD20 antibodies with BTK inhibitors when you're when you're seeing patients.
So personally, based on the recent longer follow-up of the Elevate trial, I've started to move towards adding on obinutuzumab to acalabrutinib if the patient is fit and if they have high-risk characteristics, because I discussed with them that it might cause them to have more neutropenia, thrombocytopenia, and more possibility for infection risk. But even though that is a risk, the outcomes seem to be a deeper remission, which may correlate with longer progression-free survival. So it would be kind of like a young, fit patient in my perspective.
Dr. Rogers?
Yeah, I think it depends on why someone selected acalabrutinib, who they are, and kind of what their goals are. So for older patients where the additional hematologic toxicity might really matter, or for people that very much want to avoid infusion visits, I think the efficacy of single agent acalabrutinib is certainly good enough that I don't feel like a compelling need to add that to get to the additional benefit. Especially if you're looking at people with lower intermediate risk disease who are older, the toxicity might be worse, the burden of those appointments might be worse, and they're probably only going to take one therapy in their natural lifespan. I don't know that the benefit of that additional improvement in PFS really favors the hassle and the toxicity. I will say the breakdown of that, where you see those with 17p, there doesn't look to be a huge advantage to the obinutuzumab there. Of course, the sample size is smaller. So I'm not sure in that particular high-risk setting it really matters either. So I have not used that much except for, as Dr. Barrientos was saying, people with concomitant autoimmune cytopenias or a need to reduce disease burden quickly. Because I don't know that for most of the patients I'm prescribing it for, the toxicity is worth the payoff. Although I certainly would for the patient she was describing.
I would agree with what both of you say, and Dr. Woyak, at Ohio State chaired the initial study with that with that combination that was published in Cancer Discovery. And what's impressive, because a number of those patients were mine on that combination, is that as you follow them, many of them became MRD negative with time. Some of them stopped, And so I think a question that we'll be addressing is, with doublets, particularly second generation BTK inhibitors that work better with second generation CD20 or third generation CD20 antibodies, is that as good or is these, the doublets? Before moving on, say, because we have two questions I think that fit really well with your combination. Dr. Rentos, would you consider a particular BTK inhibitor when you're combining with a BCL2 inhibitor based upon safety, safety and the data that exists right now?
I would say, based on the data that you're going to present next, I would probably choose a second generation BTK inhibitor because it's safer and you can achieve more or less the same efficacy. So that would be my answer.
Dr. Rogers, what do you?
So I think that we're expecting the first approval of a combination to be with Ibrutinib. And if you're not treating someone as a participant in a clinical trial, I would select the one that is approved. Although I agree, I think the second generation ones are likely to be safer. So I'm excited to see how that comes along. The other thing that I'm excited about for fixed duration, Ibrutinib or other BTK inhibitor and Venetoclax combinations is that it can spare patients some of the longer term side effects of BTK inhibitors, such as atrial fibrillation and hypertension, where the incidence increases over time. So that will limit the toxicity of any of them to an extent by discontinuing it.
All right, that's great. Safety that leads into the next. Say, I'm going to talk a little bit about and the talk of the discussion that I'll lead is staying safe, understanding the toxicity profiles that informs treatment decisions. So my clinical consult will be with Jack. And Jack is a young man, 48 years old, who presents with symptomatic CLL per the IWCLL criteria. He's barely working with a performance status of 0 to 1. He has anemia and thrombocytopenia that is manageable. He's obese, has quite poorly controlled diabetes, hypertension. He did have AFib, with a very stressful event now that's medically managed, hasn't recurred, and his creatinine clearance is 40. His FISH has deletion 13q. His P53 is wild type, and he does have IGVH unmutated disease, which likely explains why he has progressed so quickly. So, what treatment options do we have for Jack? Continuous BTK inhibitor therapy plus or minus obinutuzumab, the Venetoclax plus obinutuzumab. The question is, if a BTK, would any of these agents be appropriate? And then, is there any role for chemoimmunotherapy in this patient? I'm gonna start off by saying that having say a good bit of gray hair and being conservative when I start therapy, I generally am somewhat dismissive of Venetoclax, of obinutuzumab, in choosing therapy for most of my patients because there's really only one phase 3 study. There's really that's pertinent to upfront treatment of CLL, the CLL 14 study, and that's one of the only studies where there was a great difference in progression-free survival. So it's very significant, as Dr. Brentos talked about. But the overall survival actually favored the control arm, chlorambucil plus obinutuzumab. So there was, and you usually don't see that. And so I want to see more long-term data with Venetoclax obinutuzumab, and a lot of people use it. It's a correct choice. So we're going to talk about BTK inhibitors, and then also the chemoimmunotherapy is for the IGVH mutated patients and patients with renal insufficiency. One would worry about giving fludarabine in such a patient because of neurotoxicity and and other things that can occur. So we move forward with this patient. And deciding on therapy, we really again need to consider the the other options. I've given you my own implicit bias based upon data for why I generally use BTK inhibitors We have a decade of long-term follow-up on those. And say the probably it's in my opinion, this would be a patient that I would move forward with a BTK inhibitor. And because of the hypertension, the prior atrial fibrillation, this patient has an incredibly high risk of cardiovascular disease based upon his age and where he's at. Say probably considering an agent that has a safer cardiovascular profile would be the direction that I would go. So let's talk about that a little bit and which BTK inhibitor we would choose. So, I think when we think of toxicities associated with the class of BTK inhibitors, there are some that are short, that occur very early and that go away. And then there are, there are many that sneak up on us over time and are just grade 1 or grade 2, but are incredibly irritating to the patient or put the patient at risk for long-term morbidity and mortality from other things. And those in particular are hypertension and atrial fibrillation, which correlate, although with ibrutinib, there's a distinct early atrial arrhythmia that occurs and that will continue to recur. And so in that group, say you have an overlap. So as we look at the different the different studies, phase 2 and phase 3 studies that have been done with ibrutinib, these are summarized here. And it's really challenging to look at toxicity because when you're doing it, and if there are any fellows in the audience, if you build your career on toxicity, get ready to have a lot of tomatoes thrown at you, because we all get excited about new drugs, and as you're developing a new drug, there's the tendency to say, "Oh, that's related to something else." The patient didn't talk about their joint pain before; they didn't talk about the atrial fibrillation. And I'll attest, I was I was part of this when we were developing ibrutinib. We had the first, the second, the third atrial fibrillation case. It's like, well, this, they're old, they have hypertension. There's another reason for this. And we all have our implicit bias, and particularly when you see a patient getting better in front of you. And really, this is the sort of the value of phase 3 studies, because they take out that subjectivity of the investigator, and say, and even when they're not blinded, you can't say you can't fudge, say if somebody has AFib or their blood pressure is going up, or if they have an infection that requires and again, the best example of this too is bruising. And say when patients started, when we started with ibrutinib and we started seeing bruising, there was more attention to that as you brought second generation BTK inhibitors forward, because we knew about it. So this really outlines the toxicity in the different phase 3 studies. And what I'll call attention to, what's important is you do see grade 3 and 4 hypertension and atrial fibrillation that clearly is higher with ibrutinib in many of these studies versus the control. As we look at acalabrutinib, say, again, and zanubrutinib, a second generation BTK inhibitor that is more selective. So it hits BTK, but it doesn't hit many of the other targets. We have less atrial fibrillation, less hypertension. But again, the people that were involved in these studies had their implicit biases. Who are those people? I guess I'll raise my hand. So I think many of us in the audience could raise our hands. And so again, it still comes down to the golden phase 3 study, where you compare the first generation BTK inhibitor to the second generation BTK inhibitor. So what about the head-to-head comparisons of BTK inhibitors in CLL? And before I show these data, I'm going to say again, as the historical person up here, that the best way to have done this would have been to have done a randomized, blinded study where you put you gave ibrutinib and zanubrutinib in unidentifiable tablets, and there were all kinds of geopolitical pharmaceutical reasons that didn't occur. That would have been the best way for it to have occurred. But the drugs are given on different schedules. You would have had to have had pharmacyclics cooperate with say with the other two pharmaceutical companies that were developing these, and it would have been wonderful if that would have been done, but it wasn't, for reasons that I think somebody is writing a book about at this point. So let's talk about the data in a unblinded way. The Elevate relapse and refractory study was the first comparison, that's been now fully peer-reviewed and published, that compared ibrutinib versus acalabrutinib in high-risk relapse and refractory CLL. This was an open, an ongoing. It's ongoing, but it's done. It was an inferiority trial. It hit its endpoint. It included high-risk patients with deletion 17p and deletion 11q CLL. The performance status of 0 to 2. The primary endpoint was progression-free survival to show the two were equivalent. The secondary endpoints were atrial fibrillation, grade 3 infection, Richter's transformation, and overall survival. And that each of those were examined in that successive order. If one did hit, the analysis was done. So we won't show statistics for a lot of the side effects, that occur, because they weren't part of the primary, secondary endpoint. But you can see in the curves, a picture is worth 1,000 words in many cases. This was a brave study to do, because ibrutinib is a great drug, and there are faults with this. There are faults with this study that were not known. The 11q patients do very, very well with BTK inhibitors in general. And so really, kudos to the the study group at Acerta, for moving this trial forward. But what's the answer? The answer is they look pretty darn close to the same. This looks at the progression-free survival over time in high risk patients, and they're the same. This is the survival. The survival is statistically not different. The hazard ratio is 0.59 to 1.15. So, it crosses 1, but it is 0.82, and it does favor acalabrutinib. We'll see what happens with time. These patients will continue to be followed as more go off. It's going to sort of be hard to interpret this, but at least the survival is going in the right direction for a second generation BTK inhibitor. What about those events that we care about in the patient that we were talking about? Time to atrial fibrillation. What you see with this, what this curve here is, with ibrutinib, you see this early flex, whereas the curves. So the curves look different here. When you get out here, they look the same, and one sees that hypertension is successively going up. It's going up more with, and really, say with ibrutinib, there probably is an off-target intrinsic cause, and this has actually been published now. One of the off targets of ibrutinib and not of acalabrutinib or zanubrutinib that does appear to be related to inhibiting of Src kinase and promoting atrial fibrillation early in patients who are predisposed to this, and then later atrial fibrillation that occurs with all the BTK inhibitors that we don't understand. That probably is related to hypertension and cardiac remodeling, and lots of people are interested in this. Very interesting biology. So, what about other? What about the details of this? Again, we've talked to some extent about this, But, in some, we see that the frequency of this is significantly higher with ibrutinib as compared to acalabrutinib. And again, even if people weren't blinded to what drugs they're taking, I've not had atrial fibrillation, but I would guess from the symptoms that I've seen patients have with it, it's not something that you could fib. It either occurs or it doesn't occur. What about other events? The variety of other secondary events or secondary toxicities that were shown to be different in this study, and really outside of headache and cough, all of the other secondary adverse events were more common with ibrutinib than acalabrutinib. And again, this is just shown here, time to event. So we have a second study, the Alpine study, that took us another second generation BTK inhibitor, zanubrutinib, and compared it to ibrutinib. And this study is different. This study had the primary endpoint of overall response rate, looking at up to 36 months. It included all relapsed CLL patients, and there was a preliminary presentation by Dr. Hillman at this past EHA meeting. And again, they showed a superior response rate with zanubrutinib as compared to ibrutinib, and then an unplanned look at progression-free survival that showed a difference. And again, this was not a pre-specified analysis, and so I worry about how to interpret this. And a common question is, was zanubrutinib better than acalabrutinib? I don't know. You can't, different patient populations done at different times. Say Beijing and AstraZeneca will partner and do a study comparing their two drugs, and we'll know the answer to this. Probably not the most useful for trial resource, though. This again shows the same time to event, and lo and behold, you even see it better on this. In this, that you see this flat frequency of atrial fibrillation that goes up with time. Whereas with ibrutinib, you see this real quick flux during the first 3 to 6 months of therapy. And again, when I see a patient develop AFib that didn't have AFib in this early time period, they're done with ibrutinib because they're predisposed to this, and it's going to recur almost always. So we have we have our clinical consult here. Jack, we talked about this. He was young. Young patients I like to treat with acalabrutinib plus obinutuzumab because of I believe CD20. I don't like to take away therapies that I know in the past have prolonged survival in CLL unless there's a chance that it's affecting the adverse outcome. It's going to have an adverse outcome in the patient. This patient had an exceptional response. He went into complete remission. We kept him on his acalabrutinib, and he developed a pruritic rash that just came on, and he just couldn't talk. It was horrible. He was just itching all the time. He was on Benadryl. Didn't like that. So what are our options at this point? Can we change the BTK inhibitor? Can we do Venetoclax? Can we observe off therapy? And I'll tell you what we did with this patient. He had no disease. We observed him off therapy, and he's still off therapy. So as we think of BTK inhibitors and the safety monitoring, let's talk about a few things. This class of drugs in general, ibrutinib, zanubrutinib, acalabrutinib, there's no safety data with warfarin, with the second generation molecules. That's because with the first generation molecules, very early on, there were 5 patients that got spontaneous subdural hematomas, and one that ultimately died. When these 2 were given. If I give anticoagulation, I usually will give I would usually give a 10A inhibitor, a thrombin inhibitor, but I stay away from warfarin. For new onset AFib, the time of onset and also the repetitiveness is important. Again, early onset, we can talk about this later. I switched to a second generation, or to a non BTK inhibitor class. and for AFib, if I'm seeing somebody that's young that has this and that's recurrent or that comes in like this before I'm going to start, I often will have my EP doctors see them to see if they have recurrent AFib, if an ablation procedure is going to help them. For hypertension, I manage with antihypertensives. If somebody's on it comes on, they're on one medicine, they on two, they're on three. I often will switch them to a second generation if they're on Ibrutinib, and sometimes you see that improve. Sometimes you don't. Say it's say I think it's an area of active study for the arthralgias. I love magnesium and calcium. Sometimes that helps with that with Ibrutinib. I generally don't like to dose reduce, although you can do that. If patients develop high-grade arthralgias, I generally will switch to a second generation or stop the drug. So with headaches, again, say starting at a low dose with acalabrutinib, that can sometimes help. Yeah, and if they're unbearable, say with a single dose, then I'll switch. I sometimes will use a first generation because the headache seems to be worse with second generation molecules. That only occurs in a few patients. Acalabrutinib shouldn't be given with a proton pump inhibitor. It affects absorption. We'll see if the new formulation addresses this. And then with neutropenia, this is seen more with zanubrutinib for reasons we really don't understand. And generally I dose reduce for that. Although although it's reported in the study, I've not seen it that often. We'll finish last with the don't lists for safety with BTK inhibitors. Don't treat asymptomatic patients. Don't treat patients without adequate education. This is where the pharmacist is great because if a patient, you tell a patient a drug is real tolerant, it's a pill, they're going to do great on it, and then they have horrible headaches. You're not going to get a Christmas card from that patient. And these drugs during the first month of therapy can be challenging. And that leads to something I see very often is that patients will be given the oral drug, they'll be sent out and say without education and to come back the next month. And really seeing patients weekly, whether it's first generation or a second generation until they're doing well is good. Even if your nurse practitioner is doing that, you're not doing it yourself. Again, we said administering any BTK inhibitor with warfarin, if they have a mechanical valve, which is really one of the main reasons you would still consider warfarin, say I would use an alternative therapy. That's where I use Venetoclax or obinutuzumab uniformly. Say I wouldn't ignore the data of the comparative studies of first generation BTK inhibitors because there's going to be even more data coming forward. They're safer. They have similar efficacy, and we're there. Outside of select settings, our patients long term don't deserve hypertension or more complications. And then finally, being aware of acalabrutinib's interaction with PPIs. And, this doesn't exist with zanubrutinib, and, this is commonly where we use zanubrutinib. And it's not a small population, the older patients. Turn things over to Dr. Rogers at this point.
So I'm the last up, and I'm going to talk about sequencing. So hopefully everyone's still awake for this. I know it's early. So I'm going to pick back up with the original case that we started and have an update on that as we move through sequencing. So again, just to remind everybody, this is Matthew. Matthew is 72 and had CLL requiring treatment. And just to remind everyone, Matthew had some comorbidities and did have deletion 17p and a TP53 mutation and was started initially on ibrutinib at the standard dose. So since we just talked about adverse events and side effects of these drugs, what happened to Matthew is that you can see within a month the drug was working. So the platelet count and the anemia were improving. He had some lymph nodes that decreased. He got the expected treatment-related lymphocytosis. It all looked good. And then at 6 weeks, developed painful joint inflammation that was so severe he was having trouble getting around his house and had to give up golfing. So he called and said, I can't move, all my joints hurt and they're red, they're swollen. He gets examined, Ibrutinib is held, and he started on low-dose prednisone, which fixed it all, and he thought, oh boy, that is great. So after this resolved, he was restarted on Ibrutinib with a dose reduction to 280, and within 2 days of taking the lower dose, he calls and says, oh gosh, all this inflammation is back. I was really hoping to go back to golfing, and I can't do this. Everything hurts. So I think now the question is, what are the options? Observation off therapy is probably not going to be an option because I doubt that 6 weeks of a drug is going to fix this for our patient. So really, would this require another dose reduction to something like 140 a day? Should we switch to a different BTK inhibitor, or just call it a day and switch to a different class of drugs? And I'm going to ask my other presenters to comment, and I was going to start with Dr. Bird on this one. So what do you think the best option would be for Matthew?
I think you've got several good options. I don't like to dose reduce BTK inhibitors, and so I probably further beyond where you're at, so I probably would switch to a second generation BTK inhibitor.
Yeah. It happens so quickly that my concern is you try Ibrutinib again, it's going to happen again. So I would probably switch him to a second generation just to for the concern that he's just not going to want to be on, and I really want him to be on a BTK inhibitor.
Yeah, I completely agree. I mean, this person, as was reviewed earlier, has benefits to a BTK inhibitor with the deletion 17p. You could switch to a different class of drugs that would work for toxicity, but you've really then not allowed the patient to benefit from this therapy that we all kind of discussed was going to be kind of optimal for disease management. So I agree. I would also switch to a second generation BTK inhibitor for him. So options would be acalabrutinib and then zanubrutinib, which we know zanubrutinib is not currently FDA approved for CLL, but there's certainly enough data to support its use. And then adverse events can be challenging to address, and this isn't something that you can coach people through for, a fixed duration and then say, okay, well, if you can just tolerate this for a few more weeks, we'll be finished with therapy. These are continuous, and there are some adverse events, as was shown, that increase with time on drug. So that's why it's really important to manage these for our patients. And of course, adherence to taking this drug therapy is important as well. So there are prospective studies looking at this switching from one BTK inhibitor to a second generation BTK inhibitor for intolerance. So this is specifically for intolerance, not for patients who developed resistance to the drug. And this is a dedicated phase 2 study in this population. And this is a study in patients who discontinued Ibrutinib due to intolerance, and there were criteria for what intolerance meant. They were observed off therapy, and if they had progressive disease demonstrating that they still required a therapy, they were started on acalabrutinib. This is the progression-free and overall survival from that study. You can see the overall response rate was 73%. So this clearly shows that in ibrutinib intolerant patients, acalabrutinib can be effective. But most importantly, the question is, do these adverse events recur, or are patients able to take this drug? So this is just some data from the study showing you the adverse events that were the cause of ibrutinib intolerance, and then whether or not they recurred on acalabrutinib. And you can see the majority of them did not, and those that did were generally a lower grade. So you can see there in the top, there are a lot of cases of atrial fibrillation. Only 2 of the 16 of those recurred. Arthralgias are less. Bleeding was one where it looks like you have almost a similar number. But really, for a lot of these don't recur or not to the same severity, supporting that this is tolerable. The other thing that I'm not showing you, but is true in this study, is there were more discontinuations for progressive disease compared to intolerance, which I think is really impressive when you think 100% of these patients were intolerant to ibrutinib. So this was also done with zanubrutinib, and I think that this also supports the idea that if one of these BTK inhibitors is not tolerable, the other ones really are expected to be for our patients. So these are patients who did not tolerate either ibrutinib or acalabrutinib, although the majority of patients were on ibrutinib and didn't tolerate it. And the orange boxes are for adverse events that did not recur, and blue is the ones that recurred. So you can see there's a whole lot of orange here. And of the 66 ibrutinib intolerant events, 58 of those, or 88%, did not recur. So this is prospective data with both acalabrutinib and then zanubrutinib in separate studies showing that it is very feasible to switch patients to a different BTK inhibitor and that the strategy works and allows them to benefit. All right, so we will return to Matthew. So he decides to take acalabrutinib and it goes really well for him. He goes back to golfing. None of his joint pain recurs. He did get some headaches during the first kind of like a month or two of therapy that kind of went away the longer he was on it. And he thought, boy, this drug is absolutely fantastic. I'm living my life. And then after about 2 years, he comes to clinic and says, oh, I think I might have some enlarged lymph nodes again. And sure enough, his lymphocyte count has increased quite a bit, and his hemoglobin, while still normal, had decreased a little bit. So he gets further testing, which shows that he has a BTK mutation. He's the BTK C481S mutation. So he has a marker of molecular resistance in addition to what looks like overt evidence of clinical disease progression. So both, ibrutinib, acalabrutinib, and zanubrutinib all bind at the C481 residue on BTK, and this mutation in the drug binding site is known to confer resistance. So now that this has happened, it's clear that some sort of change in treatment is needed. So there's some options for what to do. So I guess one question is, what about zanubrutinib? Could that be used? I just told you it has the same exact mechanism, but that's a question that I get asked. Could you do a PI3 kinase inhibitor? What about Venetoclax? And then, there's some other options that I think are very good ones, including a clinical trial with a non-covalent reversible BTK inhibitor such as pirtobrutinib. And then what about cellular therapy, which has become very exciting in hematology in general and in CLL, or a different type of clinical trial? So I'll just start by saying zanubrutinib is not expected to be effective. And with the PI3 kinase inhibitors, there's not a lot of data to support that. It is also upstream of BTK, so I wouldn't expect that to be effective. But the other three options are all potentially good ones. And I'd love to hear what my co-presenters have to say about those. And I'll start with Dr. Barrientos this time.
So if I am able to put the patient on a pirtobrutinib trial or as compassionate use, I would prefer to stick with a BTK inhibitor. But if that is not possible, then I would possibly do Venetoclax because we have prospective data.
I agree. Sticking with the same class of drugs, the fact that they have a CYS41S mutation tells you that the CLL is dependent upon, this target. And pirtobrutinib or another reversible BTK inhibitor, it would be a great option. Or a degrader. Now we have degraders.
Yeah. I completely agree. I also think that you have a patient that can continue benefiting from inhibition of a target. It's better to continue to utilize that to control their disease rather than switching classes of drug. And then there's always a question for an individual you're taking care of whether or not a clinical trial is something they can actually do, like just from a feasibility or individual person standpoint. So I'm going to show you data with Venetoclax, which is FDA approved and is the only standard of care FDA approved drug that is known to be effective in this situation. So it's actually very important. And then again, PI3 kinase inhibitors may work, but there's not a lot of data with that. And then clinical trial options are outstanding for someone in this position, including drugs like pirtobrutinib or other reversible BTK inhibitors that bind at sites other than that C481 residue, BTK degraders, and then, completely novel mechanism therapies are also exciting. So Matthew elects not to go on a clinical trial. He says, I don't want to do that. So he gets what is the most effective known standard of care in this situation, which is Venetoclax, and he is treated as per the Murano Trial. So that's 2 years of Venetoclax with rituximab during the first 6 months of therapy. He has a very nice response, goes back to golfing. He does develop some neutropenia, but never gets infections. And everything goes really well for him. That's a 2-year fixed duration regimen. But about 6 months after the completion of the Murano regimen, so 6 months off therapy, he then again notes that the lymph nodes are coming back and he is developing lymphocytosis. So he has clinical disease progression after completing this Venetoclax regimen. And again, sequencing is done and he has persistence of the BTK mutations, but also something we do see in our patients, which is multiple Plc Gamma 2 mutations that are found. So now the question is, well, what do we do? What do we do for Matthew at this point? Do we try a BTK inhibitor Venetoclax combination? Do we retreat with something like a Ibrutinib? Because he says, boy, that was pretty tolerable and worked. Should we do that? Do we go to a non-covalent BTK inhibitor? Is that something that is still going to work in this circumstance after he's now progressed on both a covalent BTK inhibitor and Venetoclax? And then again, there's PI3 kinase inhibitors, which is kind of the one approved or standard of care therapy he hasn't been exposed to. And then what about cellular therapies? He asked you about that. He read an article online, says, hey, can I get this CAR T stuff? That sounds neat. So I think there's a couple options for what to do, and I have my preferences, but I'd love to ask my co-presenters too, and I'll start with Dr. Burt this time if he's willing to share.
I think no matter what you choose, you're in trouble.
Yeah.
Say, probably this is somebody. The BTK inhibitor Venetoclax combination is going to probably be active for a short period of time, as is the PI3 kinase inhibitor. But you need something. You need something that's going to induce a durable remission, and it's going to be something on a trial probably. And if you something with cellular therapy.
Yeah, it's tough because he had a relapse that was like so short, and then he has all these mutations. So CAR T therapy or another clinical trial, I don't see, like you could, while you get him to trial, you could consider PI3K, but it would be as a bridge to getting him like some more.
And with the Plc Gamma 2 mutation, he's not going to respond to a BTK inhibitor. That's just an important thing for people to recognize.
I think the first thing you said was probably the most substantial, which is this is a problem. Like this person's in trouble. And I find that, CLL, everyone has worked so hard over years to make therapy not only more effective, but also safer and more convenient for our patients. And I find that some of them are then surprised when you talk about something that requires clinical trial visits or something really involved like CAR T therapy. They're like, wait, where's the third pill I can just take and go back to golfing? What do you mean this trial means I have to come once a month? I don't understand this. And so I think that even though you might have discussed it, and I tried to at multiple points along the disease course, especially when people become resistant to a BTK inhibitor, that what you have to do is build this expectation. It might get more difficult in the future, but people are still surprised when you suggest doing something less easy than just take these tolerable pills and go back to your life. And still, the clinical trials are good options. They're not, as intensive as they could be, but it is a big change. And I think that, with reversible BTK inhibitors with the PLC gamma 2 mutation that's downstream of BTK, so that's not a good option, although there is data with Ibrutinib that it can work in patients that are resistant to both Ibrutinib and Venetoclax with BTK mutations. So, the fact that they're resistant to both doesn't mean necessarily for everybody that won't work. But with the PLC gamma 2 mutation, that's a little different. But this is really a time to enroll on a novel mechanism study and then definitely to have a heart-to-heart about CAR T therapy, see if they can do that. So those are kind of the options we discussed. Okay, so this was shown earlier, and I'm showing it again here just to look at kind of what happens to people taking Ibrutinib. And again, this is Ibrutinib because this is kind of longer-term data. There's more experience with Ibrutinib. And the graph is showing you cumulative incidence of discontinuation, and you can see both other events, which is toxicity and actually transformation to aggressive lymphomas kind of plateau. But the CLL progression increases the longer people have been on the drug. So this is a problem that gets worse with time rather than better. So resistance to these drugs. And I think that makes it really important for our patients. And then there's kind of a pie chart of kind of mechanisms of molecular resistance. So you can see the vast majority have just a BTK mutation. There's patients that have both BTK and Plc Gamma 2 mutations, and you can have multiple types of BTK mutations as well. And then Plc Gamma 2 mutations make up a smaller chunk of the pie. And then there is, somewhere around 20% or sometimes a little less, depending on which cohort you're looking at, where you actually don't identify either BTK or Plc Gamma 2 mutations. So something has caused resistance in these patients, but it's probably more complex than just one thing happening here. So now I'm going to show you some data on Venetoclax, and I'm going to separate it by people who were resistant to BTK inhibitor and people who were not. So this is the results from the Murano trial. This is the one I mentioned earlier that Matthew had been treated with this regimen. So it's a 2-year fixed duration regimen of Venetoclax with rituximab during the first 6 months, and the comparator here was BR. So you can see the green curve not doing quite as well. That's bendamustine and rituximab. So the one we're really interested in is the blue, which of course this was better than bendamustine and rituximab. A high number of patients in this study had deletion 17p or TP53 mutations. The important thing about this study that I think is really vital to realize when looking at it is that these patients weren't really exposed to BTK inhibitors. There were very, very few patients in this randomized phase 3 study that had been exposed to a BTK inhibitor or were resistant to it. So looking at this data is really understanding what Venetoclax will do for someone who is not resistant to a BTK inhibitor. And when you're counseling someone who's progressed on a BTK inhibitor about what to expect with Venetoclax, this isn't the relevant data. This is the data more for selection of Venetoclax instead of a BTK inhibitor during that discussion. And you can see the median progression-free survival is over 53 months, which is outstanding. This data here is the data for what to expect when people are resistant to a BTK inhibitor. So this is a specific study in patients who had discontinued ibrutinib. The vast majority had discontinued for progression, but there are some patients who were intolerant included in this cohort. And the median progression-free survival here is right around 24 months. So instead of 53 months, you're now looking at a median of 24 months for your patients. And this is expected. The more things people have been treated with, the less well future therapies work. So it's this is an expected thing to see after resistance to other drugs, but it's important because the duration of the Murano regimen for Venetoclax is about 24 months, which is the median of what to expect here. So if I'm talking to someone who's resistant to a BTK inhibitor who chooses Venetoclax, even if we use the Murano regimen, and this was a Venetoclax single agent monotherapy study, I don't counsel people that they can expect 2 years of Venetoclax and then being observed off therapy, because I know that a good number of patients will progress before they get there. I'm not saying I don't discontinue therapy with Venetoclax in people with a deep remission, but you just can't expect the same benefit. This is data from the Murano study again. So this is going back to the non-BTK inhibitor resistant population. And this is looking at treatments that patients took after finishing Venetoclax and rituximab and then progressing, and specifically those who took BTK inhibitors. The BR arm data is included on this slide as well. But you can see the overall response rate for people who took a BTK inhibitor after finishing the Murano regimen with Venetoclax and rituximab is 100%. So this really supports that BTK inhibitors are effective when given after Venetoclax. This is not prospective trial data. This is retrospective data. And this is now going back to the population of people who had progressed on a BTK inhibitor and then progressed on Venetoclax. So this is a study looking at people who progressed on Venetoclax. And you can see that the progression-free survival for patients who had not taken a BTK inhibitor is good. But if you look at the far side, they have progression-free survival for BTK inhibitor-exposed patients. The blue line is those who discontinued for adverse events, and the kind of gold line is for people who had progressed on a BTK inhibitor. So what you're seeing is that those who progressed on a BTK inhibitor and then progressed on Venetoclax, you don't really expect a good benefit if you go back to your BTK inhibitor. And this actually seems obvious. So once you've become resistant to a drug, doing something else and then going back to the drug is not a good strategy. I just think it's really important to highlight kind of these differences with the Venetoclax outcomes in patients who are resistant to BTK inhibitor versus those who aren't. And also just showing that Matthew's question of can I go back to acalabrutinib, the answer is that's not going to work. So what can we do with BTK inhibitors still? So there's BTK inhibitors that are non-covalent, reversible, and actually bind at a different residue. So it's showing you ibrutinib, which has these answers are also true for acalabrutinib and zanubrutinib here. Under the ibrutinib column, we're just showing you one of those. And then ARQ-531 pirtobrutinib, which you've heard us talk about, and SNS062. And those are all reversible non-covalent BTK inhibitors that do not require the C481S residue. So these are drugs that should be active even in the presence of the C481S mutation. And they're all investigational at this point. So here's some data with pirtobrutinib. It's showing you the kinase map. And then here's some clinical data with pirtobrutinib from the Bruin study. And this is just the kind of waterfall plot on change in lymph nodes. And it's colored by prior therapies. So you can see the dark blue is discontinued BTK inhibitor for progression. And the red stars on the bottom are people that had previously taken a BCL2 inhibitor. You can see very good efficacy even in this population. So it's really exciting to see that pirtobrutinib can work. And you'll see the little kind of crosses are people with the C481S mutation, and you can see a reduction in disease. So pirtobrutinib, which is a reversible BTK inhibitor, is active in this setting. It can also be given to patients with prior BTK inhibitor intolerance and is generally tolerable. Okay, and then the last thing we were kind of talking about, which I'll cover briefly, is CAR T therapy. So this is data from a phase 1 study of liso-cel in patients with CLL. This was done in a very high-risk CLL cohort. So this is patients like Matthew. You either had to have high-risk disease and failed 2 or more prior therapies, or if you have standard cytogenetic risk disease, you had to fail 3 or more. So these are really patients that don't have good standard options and would benefit from something like cellular therapy to have durable disease control. And they were collected for CAR T manufacture, treated with lymphodepletion. Liso-cel was infused, and there's 2 different dose levels that were used, and then they were followed after that. And you can see the study really selected who that kind of meant to, which is high-risk patients. A good portion of patients had received prior ibrutinib and Venetoclax, including those with progression or failure of those. So here's some of the response data, which I think is really exciting. So it is broken down by dose level and by total. And if you look, there's a good number of patients who achieved a response. So it's not that people universally responded, but this is a very good overall response rate for patients in this situation where you really don't expect any standard drugs to work. I mean, you've got 82%. That's pretty outstanding. And what's more is they're showing you the MRD rates, and patients that had undetectable minimal residual disease were more likely to stay in remission. Here is a duration of response, and then I always like to look at progression-free survival. And there are patients who progress on this study. Again, this isn't something that's going to completely fix CLL for everybody. We don't expect that in this population. But the exciting part for me is really to see the shape of this, where you've got a flattening, where you're seeing a good number of patients are really deriving a durable benefit from this. This is going on into a phase 2 study, and I fully expect as our technology and ability to safely and effectively deliver cellular therapies to patients improves, this will really benefit patients, particularly those with resistance to our targeted agents. All right. So here's my summary on this. So just because these are very different, I thought it's important to make this points 1 and 2. BTK inhibitor intolerance does absolutely not exclude this class of drugs and can be managed by switching to a different covalent BTK inhibitor. So for ibrutinib, acalabrutinib is also approved, and zanubrutinib, while off-label, is in the NCCN guidelines for intolerant to other BTK inhibitors. BTK inhibitor resistance, though, does require change. So you can either move to a totally different class of drugs, Venetoclax being the most proven, or a different type of BTK inhibitor, which, as we discussed, is probably the most exciting possibility. And then I think we've also made the point that patients with BTK inhibitor resistance really do require a long-term strategy. The duration of benefit of other standard therapies is not likely to be long, so you really have to talk to people about what you're going to do down the line. And then BTK inhibitors are effective after Venetoclax, but only in patients who did not previously have resistance to them. Okay, so I'll end there.
That was great. We have several questions about intolerance, and we're getting to the end of the symposia. We're getting to compete with the music too.
Yeah.
But I one question, and I think that's relevant to this, to this great last talk that we had is, do you routinely check for BTK or Plc Gamma 2 mutations after treating with Venetoclax in a patient who's had a prior BTK inhibitor? And
So you mean if you're going back to a
yeah,
BTK inhibitor?
or if you're just deciding what you're going to do next.
Yeah. So, in people never exposed to a BTK inhibitor, you really don't find those mutations, so I don't check. But in patients who were previously exposed to a BTK inhibitor, I do, because I think it really informs the discussion with the patient as to what you're going to do next. And I would not treat someone with a covalent BTK inhibitor if they have a mutation in BTK or PLC gamma 2.
Dr. Brentos?
I would do the same. Essentially, if they have the mutation, then definitely would prioritize that patient to participate in a Ibrutinib trial or another non-covalent BTK inhibitor.
Yeah, I would agree. I just moved to the University of Cincinnati, and before unpacking my boxes in my office, I was sure that for my patients, I had mutational testing set up that was sensitive and that includes all these, because even if patients didn't have them before, I've seen patients hop up with BTK inhibitor. If they've had a BTK inhibitor, they didn't have a mutation before, you treat them on Venetoclax. What comes back is often different because these BTK clones have a fast growth curve. What about age in deciding with your patient? Would you send a 72-year-old to CAR T-cell?
If the patient is fit, age doesn't matter, honestly.
I completely agree. I think if the patient is fit, I would definitely still consider CAR T cell therapy. I do find that people in their 90s usually aren't open to doing CAR T cell therapy. So you do get to a certain point where, like, in the context of their life, it doesn't make sense. But I do not have an age cutoff for doing those. It's strictly based on fitness. And again, there are some younger patients that aren't suitable for CAR T. So,
And then there's a common question about decreasing dose with first-generation BTK inhibitors and diminishing adverse events. What's the two of your
my experience doing that is that it doesn't really help for the vast majority of patients. Like, as you know, I've tried it in some cases, and most patients have the toxicity recur, and I find that switching to a different one is much more effective.
Yeah, same here. The only times we've done it is when we're waiting for the insurance to approve the second generation BTK inhibitor.
You have a uniform agreement on that question. And then say, I hear this often, say, do you find in your practice patients don't like BID dosing? Because you have BID dosing with zanubrutinib and acalabrutinib versus ibrutinib.
Yeah, for at the beginning they don't mind. It's after they go to 6 months that they're like, "Doctor, can I go to once daily dosing?" And if they're having a good response, it's hard to tell them to stick to twice daily, even though we have some data that it's not as good. So I try to get them to stick to the twice daily dose.
Yeah, I don't tell them they can go to once daily. I find it's like patient specific, because some patients that are already on BID or TID drugs for other health conditions are like, yeah, sure, fine. I'll just put it in my pill box twice a day. No problem. This is all good. I'm already taking all these things twice a day. But the young patients who are very unused to taking any pills at all or who take only one pill are strongly motivated to do it daily rather than a BID dosing. And I have some patients where I'm like, really, if I could just get you to take this once a day, it would be great. So,
Yeah. Oh, well, I think these we've covered most of the questions. There are a few about other adverse events or individual how we would manage individual patients, and you can contact any of the three of us. We all run referral clinics and answer emails. We're easy to find, and we're happy to answer questions for any of you about anything we've talked about or other things related to CLL.
This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/HZU860. This activity is supported by an independent educational grant from AstraZeneca.